So good morning, everybody. I'm going to talk about diagnosing tuberculosis in a high HIV prevalence setting. The diagnosis of tuberculosis remains a challenge, and since smear microscopy is still the main diagnostic tool used in peripheral settings, diagnosing smear-negative patients and HIV individuals is particularly difficult. So in these populations, clinical signs and X-ray are still largely used. However, we have two tests currently available. One is GeneXpert, and the second one is TB-LAM. These two tests are very different tests. The first one, Expert, is a molecular test. It requires a laboratory, so it has to be done at the district or national level. And in a meta-analysis, the sensitivity in smear-negative patients was 67%. TB-LAM is a point-of-care test. It uses urine and is only useful in HIV-positive patients immunosuppressed. In this population, the sensitivity has been found between 30 and 65%, depending on the CD4 count and the population. So here you have in the slide the two tests. On the left side of the slide, up there, you can see the Expert instrument. It uses a cartridge that you can see in the middle of the slide. So usually you use a sputum sample. So you prepare the sputum and you put it in the cartridge, and then you insert the cartridge in the machine. You can see it down on the left side of the slide, and you get the results in 2 hours through a computer. And the LAM test is on the right side of the slide. You can see it's a point-of-care test, so it is a strip. You take your urine sample, you put a drop in the strip, and then you can read the result through a band, and with a reference card, you can see the intensity of the band. So the question is, what is the added value of these tests when they are incorporated into a diagnostic strategy? To answer this question, we conducted a study to evaluate the incremental diagnostic yield, so the performance of including Expert and LAM in different combinations into a clinical radiological algorithm to diagnose pulmonary tuberculosis in an HIV prevalence setting. This was a prospective observational study. It was conducted in Homa Bay District Hospital in Kenya, and the population was adult patients with symptoms of pulmonary tuberculosis. And we had 2 cohorts of patients. First cohort was smear-negative patients who were all ambulatory patients. You can see the picture on the slide. And the second cohort were HIV-positive patients who could be whether hospitalized or ambulatory patients severely ill or with CD4 less than 200 or with BMI less than 17. So in smear-negative patients with symptoms of tuberculosis, we evaluated 2 algorithms. First one was clinical radiological strategy, so patients received clinical exam and an X-ray. And the second one was clinical X-ray and Expert. So patients received, on top of the clinical exam and the X-ray, an Expert test. And this was done after 2012 when Expert was introduced in Homa Bay Hospital. The endpoint for all analysis was starting TB treatment, and the reference was culture positive. In HIV-positive patients with symptoms of TB, we evaluated 3 algorithms. First one was, again, clinical X-ray. Then second one was additional LAM to the previous exams. And the third one was additional Expert to previous LAM. So the 3 algorithms were evaluated in the same population. This is one cohort. And again, the endpoint was starting TB treatment and the reference culture positive. So here are the results. Patients were recruited from September 2009 to February 2011 for the cohort smear-negative without Expert. Then from July 2012 to October 2015 for the cohort smear-negative with Expert and HIV-positive. So you can see that in smear-negative patients, 65–67% were HIV-positive, and culture was positive in 15–17% of the smear-negative patients, so meaning that these patients had confirmed tuberculosis. In HIV-positive patients, always with suspicion of tuberculosis, 32% were culture positive. This difference is because, as I explained before, these patients are selected, so they were first all HIV positive, and then they were hospitalized or severely ill or with CD4, low CD4 or BMI low. Then expert was positive in 12% of the smear negative and 32% of the HIV positive, and LAM was positive in 39% of the HIV positive. So now if we focus on the characteristics of the HIV positive cohort, you can see that 76% were hospitalized, 70% had CD4 less than 200, 85 were severely ill, and 44% had a BMI less than 17. Now, one thing that is interesting is that 1/4 of the patients were not able to produce a sputum. This is because they were severe patients. And so we couldn't perform culture in these patients, but we performed LAM test, and 45% of them were positive. So here's the treatment decision in the cohort of smear-negative patients. 111 patients were started on treatment through the clinical and radiological algorithm, and among those started on treatment, 30% were culture positive. In the cohort who received expert, 186 patients were started on treatment, and among them, 30% were culture positive. So when we calculated the diagnostic yield of the two strategies in this cohort, we can see that 55% of the patients who are TB confirmed, so culture positive, were properly started on treatment, which means that 45% were missed by the strategy and were not started on treatment. When we add expert to the strategy, this proportion goes up to 87% of the patients TB confirmed started on treatment. And when we look at the patients who were started on treatment, we see that 70% were culture negative. If we use culture as a proxy of diagnosis of tuberculosis, majority of these 70% of patients probably did not have a TB. And the same proportion was with expert, in the cohort with expert. So here is the cohort of patients HIV positive with symptoms of TB. So again, among patients with culture results, through clinical exam and X-ray, 142 patients were started on treatment, and among them, 41% were culture positive. When LAM was added, the number of patients went up to 213, and when expert was added, the number of patients went up to 228. When we calculate the diagnostic yield, again, a similar proportion, 55% of the patients who are TB confirmed were started on treatment after clinical exam and X-ray. When LAM is added to the strategy, this proportion goes up to 80%, and when expert is added to the strategy, this proportion goes up to 92%. And when we look again at the patients who were started on treatment and how many were culture negative among them, we can see that the proportion does not change, is around 60% with all the strategies. So now if we look at the diagnostic yield in HIV positive by group, you can see that there's a similar proportion in all groups. So through clinical exam and X-ray, around 50–60% of the patients were started on treatment. And when LAM was added to the strategy, again, 77–85% of the TB confirmed patients were started on treatment, and when expert was added, again, 89–90% were started on treatment. So in summary, there was a high incremental diagnostic yield by including expert and LAM test into the clinical exam and radio and X-ray diagnostic strategy. In smear-negative patients, 80% of the patients who were TB confirmed were properly started on treatment using an algorithm that included expert. In HIV-positive patients, including LAM into clinical exam and X-ray allowed 80% of the TB confirmed patients started on treatment, and when expert was added to LAM, this proportion was 92%. However, the proportion of culture-negative patients among those started on treatment did not vary. In conclusion, in smear-negative patients, XPERT should be used in the algorithm as a first test. However, it's important to do a differential diagnosis if XPERT is negative to reduce possible overtreatment. In HIV-positive patients, LAM can be a useful test in hospitalized patients and in ambulatory patients who will be severely ill, will have CD4 less than 200 or BMI less than 17. LAM can be helpful as well in patients that are not able to produce sputum. If XPERT is available, this test should be used. Thank you very much.
Merci beaucoup, Elena.